This speaker will be Professor Hackert, who is the vice chairman of the Department of General Visceral and Transplantation Surgery in Heidelberg, working face-to-face with Professor Buchler. In the center, they perform more than 700 pancreatic resections per year, so it's incredible. And he has a special focus in the robotic pancreatic surgery. He's going to talk about how to deal with anastomotic leaks. Professor Hackert, please.
Yes, can you hear me now?
Yes.
Okay, thank you very much for this nice introduction. And although we perform a lot of pancreas surgery, still we do have anastomotic leaks, of course. And I just want to summarize some topics on this. I think I have the control. Let me see. Yes. Now, we have approximately 10 to 15% of leak rates in the literature after Whipple. And you can see here, you have done a nice anastomosis, like you have seen in the prior videos. And some days later, you may have to reoperate a patient and you find something like this, which looks like a nasty necrotizing pancreatitis. And I want to come back to this topic later in my talk. Now, we have definitions, we have risk factors. We think about prophylaxis for POP. And of course, we need to talk about the management of all of this. Now, the definition I don't need to mention. Everybody knows this revised definition by Claudio Bassi and his group from 2016. We only talk about fistulas when we have a change in clinical management, type B, or when we have reoperation, organ failure, or death, then this becomes a grade C fistula, of course. Now, everybody clinically knows a pancreatic cancer is easy to suture. You have a dilated duct, you have a fibrotic pancreas. A bile duct cancer is not easy to suture because usually this is soft with a small duct. But of course, there are some things more to estimate the fistula risk. And many people use this fistula risk score. This is introduced by the US group. And you see this is not only the texture and the size of the duct, but also the type of operation, blood loss. And this gives several points and sums up to a maximum of 10 points in the end. And this correlates quite well with the fistula risk that you take from the low risk patients from 1 to 2 points in the score up to 9 or 10 points where you have a 100% more or less fistula guarantee. And if you want to avoid a fistula in this patient, you probably have to take out the pancreas right away. Then you are sure that you don't have this 100% fistula risk and you don't take this. Now, what about the anastomosis? We have just seen 2 very nice videos, quite similar to the technique that we perform every day as well. And this is an ISGPS statement that was published in 2016, how to do the anastomosis to perform best. And you see, preferred is a pancreatic jejunostomy, duct to mucosa, or invagination technique. You should not change your technique when you do a portal vein resection, for example, when you do more extended resections. You should use the suture material we heard about, like 4-0 or 5-0. We always use these monofilament sutures as well, as we have seen in the videos too. Regarding other measures to prevent fistulas, stenting is kind of recommended in this ISGPS statement, but you can see that the agreement is weak. We do not use a stent at all. What about somatostatin? You might use it in some critical patients. I will also come back to that later for a brief comment on that. You should not use a double loop reconstruction because there's evidence that this is not helpful to prevent fistulas. Drainage is recommended here, but once again, only moderate agreement. Also, the next slides will show you some data on this. Should we use any tissue sealant or cover the anastomosis? The answer is clearly no. And whenever you have a leak with a complicated fistula and you go for a reoperation, you should probably not try to redo an anastomosis, but you should think about only disconnecting the pancreas or taking out the pancreas. So these are the recommendations by the ISGPS from 2016 to prevent fistula and do the best anastomosis you can. Now, what about drainage? I already mentioned there was a more or less moderate consensus that you should use drains. We don't agree with that because probably most of you know the so-called PANDRA trial was a 2-center trial with 400 patients, routine drainage in Whipple procedures compared to no drainage in Whipple procedures. And when you look at the results, you see that the no drainage group had significantly less clinically relevant fistulas and associated morbidity, which is shown here. Drain group 26%, I'm sorry for that, and the no drain group 13%. So somehow this is not really working. But just the message is no routine drainage is required. Of course, still many people have the habit to do the drains routinely. We think this should be done selectively and the surgeon should decide for every patient individually. Now, what about somatostatin analogs octreotide? There are numerous studies on this, Cochrane systematic reviews, and the answer is no, it has no impact on reoperation, hospital stay, or mortality. It might have some impact on the overall morbidity, but not on the clinically relevant fistulas. So most people, I think, have omitted the routine octreotide prophylaxis. We use it selectively in soft pancreas, but we don't use it for therapy of fistula, for example, only for prophylaxis, and this is very selectively. Now, we already heard in the beginning of the session about the impact of interventional radiology, and I think this is a key thing to handle pancreatic fistulas. Very old paper from the US, but what you can see here is you have 10,000 Whipple procedures. 12% of these patients needed some radiological intervention, and you can imagine, otherwise you would have done reoperations on all of these patients to handle these complications if you had no interventional management. This is, of course, aspiration of fluid collections, PTCDs, and of course, bleeding management with embolization or similar measures to prevent bleeding. And what else you can see is when you do this, you can dramatically reduce the rate of your reoperations to only 4% due to pancreas fistula-associated complications. Otherwise, remember, it would have been 12 or 13% of the patients, so only 1/3 or 1/4 of the patient in the end need a reoperation. This is an example. You have seen these pictures in the beginning of the radiological talk, so I can just skip this. I think is not so interesting. What about the associated complications with pancreatic fistula? Of course, the worst one is bleeding, post-operative or post-pancreatectomy hemorrhage. And this is a 15-year-old study from the Dutch group comparing a study group and a historical control group. I don't want to go for the management. I just want to show you these key features. What are the patients at risk for bleeding? These are the ones that have a sepsis before the bleeding occurs. Of course, they more or less all have a pancreatic fistula in behind. This is the cause for the sepsis and the cause for the bleeding, of course. And I think the most important message from this paper is that nearly all of the patients, 78 or 100% of the patients, do have a sentinel bleeding before they have the dramatic hemorrhage itself. And this is the thing that you should always have in mind. If a patient shows a little bleeding, he will go to a severe bleeding. And this is how you handle these patients. You have to be critical. And then you have to go for the interventional management, of course. We used to do coiling very long time from our colleagues from the radiology. Nowadays, we prefer the stenting of the GDA stump because coiling has its own problems with dislocated coils and things like that. And the stenting is a very elegant method, I think, where you can fix these things. What about our experience with the interventional management? We have analyzed 25 patients with a late hemorrhage after Whipple procedures. In the CT scan, you had 92% successful location. Afterwards, you go for angiography. And what else you see is that sometimes this bleeding can occur very late, 3 weeks in median, but also up to 290 days after Whipple procedure. You need a lot of transfusion, 7 packed blood cells. Successful embolization can be done by the radiologists, but still you have a 20% mortality in this really severe fistula-associated complication of bleeding. So this is really something you have to handle. Sentinel bleeding, go for the ICU, do the CT scan, do coiling or stenting. If necessary, go to the OR for hematoma evacuation. And if required, very severe fistulas, maybe salvage pancreatectomy. Now, what about salvage pancreatectomy? These are some old data from Heidelberg. And I just want to show you the mortality of emergency salvage pancreatectomy. And you see this mortality is 40% compared to below 5% for elective total pancreatectomy. So we don't prefer to do this. Have to be very careful with these patients, not only in Heidelberg, but also, for example, in Hamburg, salvage pancreatectomy, 55% mortality. So we should really be restrictive, but we should also not miss the point when we need to do a salvage pancreatectomy. The Dutch study group, of course, had another idea. They compared a kind of a step-up approach of interventional management for these very complicated fistulas B and C, and compared this to an upfront surgical approach with a remnant pancreatectomy. you see also in the Dutch study group, overall mortality for these BC fistulas, 18%. But very important, when you go with the drainage and increase the drainages, you have a mortality of 15% or 14%. When you do an upfront operation, salvage pancreatectomy, same mortality as I showed you before, approximately 36%. And I think this is considerable, this number of mortality that you produce. And the other endpoints in this study, you see not only mortality, but also organ failure is less when you do the interventional approach than when you go for laparotomy. And of course, also the long-term complications. I mean, this is self-explaining. If you take out the pancreas, you do have diabetes. If you do it interventionally, you can keep the pancreas. So you should be as conservative regarding salvage pancreatectomy as required as ever possible. Now, I started with this picture in the beginning. You see this anastomosis with a necrosis, but the problem is sometimes you don't know what's behind. This can either look like this. This pancreas looks quite nice. Only the first 2 centimeters were necrotic. So we could have kept it in, put in some catheter in the duct and disconnect this pancreas. The other possibility is same picture like this. You take out the pancreas, it might look like this, and you have a severe necrotizing remnant pancreatitis. And of course, this pancreas has to be taken out immediately. Therefore, I just want to focus for the end of my talk on one thing that is a big debate at the moment in the international study group, the problem of post-operative pancreatitis after Whipple procedure. This is our view from our Heidelberg data. We have analyzed approximately 1,200 Whipple procedures, and we have just defined that we need a CT scan as a gold standard to define a post-operative pancreatitis. Why is that? Because we know that a lot of patients show an increased amylase on day 1, day 2, day 3 after Whipple procedure. But when does this become dangerous, this increased amylase? This is the question, and this is our results. This is the patients who are very low amylase, no changes here. This is the patients who have an elevated serum amylase on day 1, day 2 postoperatively, and these are the patients serum amylase with the necrotizing postoperative pancreatitis. So you can see there are considerable differences in this, but this is not only equal to a postoperative pancreatitis. This is just serum amylase at the moment. What does make the risk for this? Of course, you have the usual risks like a high BMI, like very sick ASA patients, and vascular resections, extended procedures. They, of course, increase the risk of manipulating the pancreas too much and having, in the end, a necrotizing pancreatitis. Outcome characteristics, when you have this necrotizing pancreatitis of the pancreatic remnant after Whipple, you see that all of these complications, including, of course, the fistulas, the bleeding, the reoperations, completion pancreatectomy, and also mortality, is significantly higher than when you only have an increased serum amylase. So this, from our point of view, makes the difference, and therefore we require the CT scan to show a necrotizing pancreatitis of the remnant, and then judge these patients right. Because when you do have this necrotizing pancreatitis, you have 12% mortality. If you do a remnant pancreatectomy, I showed you the historic data from our center was even higher at 40%. So I think just to define this a little bit, a hyperamylasiema on day 1 is frequent. To define a real necrotizing pancreatitis, you need a CT scan or an intraoperative finding. You have an association of this necrotizing pancreatitis with a fistula, of course. You have an association with a mortality. And from our point of view, we should judge patients from serum amylase, CRP, and of course the CT scan. And when we do have this so-called co-op, you should consider early salvage pancreatectomy, because otherwise the situation might become dangerous. Now, to conclude on all the topics that I just told you, risk management and prophylaxis of fistula, octreotide-only selected patients. You should have a standard anastomosis, as we have seen from all the speakers now that have shown the anastomosis. We do not believe in a routine drainage. If you have a drain, of course, you can control the amylase and the lipase. If you have a CRP elevation, do a CT scan very early. Interventional draining is, of course, what we prefer. The same for hemorrhage, interventional management, and revision salvage pancreatectomy only in abdominal sepsis or in proven post-operative necrotizing pancreatitis after Whipple. And then we hope that we can handle these complications, which might otherwise be fatal. Thank you very much for your attention.
Thank you very much, Professor Hackert. We don't have any question from the audience. We are very late. So just one question for you. What about the use of stents to prevent fistula?
If we use or if we do not use?
If we use.
We do not use a stent except for robotic Whipples where we do a Bloom guide anastomosis. But in open surgery, we never use a stent.